Hello guys, this is Dr. Asif. Today I'm going to discuss about a long case that is a bladder cancer. In the previous class you saw my urogenital cancer, which is very common, that is renal cell carcinoma. So as the continuation of that videos, I'm going to discuss about the bladder cancer. So it is very important in your final exam. Okay, first you have to explain your a long case within 5 to 7 minutes. That is, my patient Mr. X, 60 years old, normotensive, non-diabetic smoker, textile worker, hailing from Jiltuli, Faridpur, presented with the complaints of passage of blood in the urine for 6 months, loss of appetite and generalized weakness for 3 months, and according to the patient's statement, his presenting complaint started about 6 months back. Then he noticed passage of blood in urine that is painless, episodic, and during the terminal part of the micturition. So here you can see some quotation points like terminal part. You can see some notice passage of blood and loss of appetite, general weakness. These are the quotation which is the things that you should remember, because in your exam your teacher will ask you what are the points in favor of your diagnosis. So you will give the points from very beginning. Okay, so let's continue. So he noticed passage of blood in the urine that is painless, episodic, and during the terminal part of the micturition. He experienced 5 to 6 times in last 6 months. Each occasions continues for 2 to 3 days and relieves spontaneously. Sometimes he also experiences passage of clot and fleshy material in urine for last 1 month. He also complains of loss of appetite and generalized weakness for last 3 months. He gives no history of evening rise of temperature, burning of micturition, fever with chills and rigor, and any renal trauma, bleeding disorders, or taking drugs or food that make the urine colorful. His bowel habit is normal and no abnormalities in urinary system. He has no history of cough, hemoptysis or chest pain, bone pain or jaundice. He has no significant past history. He has no history of allergy to any foods or drugs. He is immunized. He is married, having 2 children. All are healthy. He belongs to low socio-economic conditions. He is a smoker, taking 15 sticks bidi per day. In our country it is called bidi, for last 20 years, but he is non-alcoholic and non-betel nut chewer. On examination he is mildly anemic, not ecteric. In nutritional status is average, and all other vitals are within normal limit. On abdominal examination, shape of the abdomen is normal, flanks are not full, umbilicus is centrally placed, inverted, no engrossed vein, no visible peristalsis, hernial orifice are intact, no organomegaly or ascites. Upper border of the liver dullness is present in right fifth intercostal space on the mid clavicular line. Bowel sound is present. Digital rectal examination reveals no abnormality. Even no palpable lump in the bimanual examinations, and genitourinary system and other systemic examination reveals no abnormality. So what is your diagnosis in this case? So you can see this is the carcinoma bladder, because what are the possibilities? That is renal tuberculosis, renal malignancy, carcinoma of the prostate, and benign prostatic hyperplasia. So these should be the possibilities. Okay, now I have already told you that your teacher will ask you about the positive points in favor of your diagnosis. So you can see why it is a case of carcinoma urinary bladder. So these are the points. Age of the patient, which is 60 years. We all know that more than 40 and the more elderly the patient is, the more chances of become affected with malignancy. Okay, so most common in the 60 years. Male patient is one of the factors, and carcinoma of the urinary bladder is 3 times more in male, because male are usually more smoker and they work in the textile industry and dye factory or chemical exposure or radiation exposure rather than women, because women mostly go for office work or go for housework. So they don't usually they are not don't involve in the such kind of cases, or they are not so affected or addicted with smoking. Okay, he is a textile worker. It's okay, it is a smoker. Patient presents with a painless terminal hematuria for 6 months, occasionally passes clot and fleshy materials for last 1 month. Anorexia, generalized weakness, no history of taking any drugs, foods or that make the urine colorful, no features of tuberculosis. So you can see here the textile worker, smoker, patient present with painless hematuria, and age and male. These are the factors here in this history. Therefore we can say that this is a case of carcinoma urinary bladder. Now what investigation will you suggest in this case? Like, to confirm my diagnosis, I will advise urine routine for microscopic examinations, culture sensitivity and cytology for malignant cell, and bladder tumor antigen. Ultrasound UHG of the whole abdomen with special attention to KUB, that is kidney, ureter and bladder, site and size of the lesion, any ureteric obstruction, condition of upper urinary tract and pelvic lymphadenopathy. In IVU, intravenous urography shows any irregular filling defect in the urinary tract, excretory functions of both kidney, and CBC with ESR, that is complete blood count with erythrocyte sedimentation rate. So these are the investigations we will go for, that is urine RME, USG, IVU, and I have explained the why we go for that investigations. Now for staging and grading, as you know that the malignancy treatment depends on the staging. Okay, some are curative, some are palliative. So for staging we will perform some investigation like CT scan of the abdomen. It reveals site of the lesion, muscle invasion, pelvic and abdominal conditions, and also the lymphadenopathy. And CT scan primarily serves staging of the large or bulky tumor. Okay, and MRI, which reveals for better delineation of muscle invasion and pelvic lymphadenopathy, because MRI pelvis is one of the sensitive tests. Yeah, CT scan is also, but in case of pelvic region, MRI gives a good result. And other options are endorectal ultrasound, which is about 98 to 100% sensitive in this case. So using of endorectal ultrasound is just newer investigations in our country, but all over the world it is established. Chest X-ray, CT scan to see the lung metastasis, and the bone scan or cystourethoscopy for invasion of other structure like ureter or pelvis, and other investigations for fitness for the patient. Because if we want to perform any operations, we need to make the patient fit. That's why fitness of the patient is necessary. And what is staging of the carcinoma or urinary bladder? Staging. So here you see the TNM staging, which is established here. T reveals primary tumor, and T0 means no evidence of primary tumor. TIS invent carcinoma in situ. TA, no invasion of papillary carcinoma. T1, tumor invades submucosa or mucosa, and T2, tumor invades superficial fascia, and T3A means tumor invades the deep muscle, and T3B, tumor invades perivesical fat, and T4 tumor invades adjacent structure, that is the advanced stage. And regional lymph node, that means no NO means no regional lymph node. N1 means metastasis in the single node less than 2 cm. N2 means metastasis in the single node more than 2 cm, but less than 5 cm or in multiple nodes more than 5 cm. So distant metastasis, it is very common for all, no metastasis, and A1 means distant metastasis occurs. Okay, how will you treat this case? So first I have said that treatment depends on the staging of the patient, and as you see, the treatment depends on case history. Treatment options for all stage of the disease are related below. So here this patient should be managed by multidisciplinary team approach. I have already told in another videos that in all malignancy cases you have to say before starting the treatment, that is MDT, multidisciplinary team approach. Patient should be, because you can perform a tumor board, in this case. It is also called in some cases a tumor board. So tumor board who has surgeon, oncologist, cardiologist, nephrologist sometimes, and also the oncosurgeons sometimes, or radiologist may be present in that case. So all together make a meeting and create the staging and accurate the staging, and then according to the staging they decide a treatment plan in that case. Okay, so treatment depends on stage, size of the number of the lesion, recurrence and presence of carcinoma in situ, presence or not, and the patient fitness and availability of the facility. Because malignancy treatment is costly, because it needs multidisciplinary team and their equipments and their departments and their facilities, and also the machinery support. Okay, so availability of the facility is one of the important issue. Informed written consent should be taken, and patient party should be counseled about treatment protocol, their cost and their parts and staging of the treatment, and also they have to be very cautious about the outcome, or they have to take it seriously, because anything can be happen during surgery, during post-operative period. A patient survival issue is here. So patient's party counseling is one of the important issue here in our country, not only here in our country but also all over the medical sector. Okay, so treatment options are transurethral resection of the bladder tumor with or without transvesical chemotherapy, which is given by mitomycin C, which is a solution, chemical solution, which is introduced through the bladder, and the catheter is blocked for about 20 minutes, about 1 hour. It should be present inside the bladder, then it is been evacuated through urine. And radical cystectomy, if it is a neoadjuvant chemotherapy followed by salvage cystectomy and chemoradiotherapy. So transurethral resection of bladder tumor, that is TURB, with or without intravesical chemotherapy is most common nowadays, and followed by neoadjuvant chemoradiotherapy is given. Okay, non-invasive papillary carcinoma. It is another part of the malignancy or type. Here TURBT is most common, and followed by intravesical chemotherapy by BCG or mitomycin C, and cytoscopic follow-up. If tumor spread to submucosa or lamina propria, then radical cystectomy. Okay, submucosa or lamina propria means patient is stage 2, so you have to make a radical cystectomy in this case. If tumor involves to muscle layer but no distant metastasis, the radical cystectomy with urinary diversion you have to make, because bladder is removed. That means you have to make an urinary diversion, like diversion like bladder, prostate, lymph node, uterus, cervix, upper part of the vagina, sometimes urethra. These things can be removed, and removal of the urethra home tumor invading the prostate stroma and concomitant carcinoma in situ, and neoadjuvant chemotherapy and chemotherapy. So urinary diversion, it's the one of the important issue. Temporary diversion, that is done by catheter and stent, and external diversion like ileal conduit, and internal diversion. Ileal conduit, what is it? Because ureter is attached with the ileum and make a conduit, so it's a diversion. And internal diversion at uretero-rectosigmoidectomy and the bladder reconstructions, and follow up 3 monthly interval for first year and 6 month interval for 1 to 2 years, and then 1 year. Now, what are the factors that responsible for increased risk of recurrence of bladder tumor? What are the factors? Because we know that bladder carcinoma, if it is partially treated or non-treated, it will make a recurrent. So high grade tumor, if it is high grade, PT1 disease, concomitant carcinoma in situ, multiple primary tumors, recurrent disease at the first check, and cystoscopy 3 months after diagnosis. Okay, so we must remember this. What are the factors, because it is sometimes asked in the exam. What do you mean by radical cystectomy? It is an important question. That means what components you will remove with bladder. That is urinary bladder also, prostate, uterus, cervix and upper part of the vagina, and the lymph nodes, sometimes urethra, removal of urethra when tumor invading the prostatic stroma, and concomitant CIS. What are the etiological factors of bladder carcinoma? Here the cigarette smoking mainly, that is 40%, and occupational exposure like urothelial carcinogen, that is 2-naphthalamine, 4-amino biphenyl benzidine, chloronaphthizine, nafazine, 4-chlorotoluidine, methylene dianiline, benzidine derivatives, azodize this. That means these are used in the chemical factories, like in the dye factories and chemical factories. So this exposure is a urothelial carcinogen. And occupation associated with an increased risk of bladder cancer like textile workers, dye workers, tire rubber cable workers, petrol workers, leather workers, and shoe manufacturers and cleaners, painters, hair dressers. So you can see most of the occupations are related with chemical exposure, like shoe manufacturer, cleaners, painters, leather workers, petrol workers. So all are there is a chance of chemical exposure. That's why it's occupational chances to become malignant. Now, what are the urinary bladder tumor? So, what is the type? That is primary and secondary bladder tumor. Primary bladder tumor includes transitional cell carcinoma, which is called TCC, connective tissue or sarcoma, and extra-adrenal pheochromocytoma. Extra-adrenal. So, you know, pheochromocytoma occurs in the adrenal medulla, but sometimes it happens extra-adrenal region. In that case, it is act as a urinary bladder tumor. Okay. And secondary bladder tumor is sigmoid colon prostate, that means metastatic carcinoma, which occurs from surrounding organ like sigmoid colon, prostate, uterus, ovaries, bronchial neoplasm like lung cancer. Now, what are the histological type of carcinoma of urinary bladder? What is histological type? First, urothelial carcinomas, squamous cell carcinoma, adenocarcinoma, and mixed. Okay. So, urothelial carcinoma most common, TCC. Then squamous cell carcinoma in case of bladder bilharziasis or cystosoma hematobium affected person, which is more common in the Middle East. Adenocarcinoma and mixed. Okay. So what are the pre-malignant conditions? How can you know that patient might go into the malignant form or dysplastic conditions? What is it? That is papilloma, any wart or any projection present in the bladder, leukoplakia in your tongue, schistosomiasis. I have already told you that it is a factor for squamous cell carcinoma or bladder bilharziasis. Then radiation cystitis, chemical cystitis. Okay, thank you very much for cooperating with me or watching my videos fully. Thank you. It will be helpful for your journey. I think one advice I should give you, that salient feature things that I have already mentioned, if in the first place, it should be changed by your own system or style. So it is not absolute, but it's an ideal. So I have given my best in the salient feature management. I think it will be helpful for you in your final exam, and I like to do like and subscribe to my channels, and it will give me much encouragement for better future video making. Thank you very much. Sweets.